Well, I appreciate that introduction, Russ, and I thank everybody for being here today. As a practitioner in medicine, this obviously carries a little bit of weight with me, and those people that know me and hear me run my mouth as much as I possibly can realize I carry just a little bit of passion about healthcare and healthcare reform. I have to say I'm ecstatic to hear what these gentlemen have to say. I think we have a wonderful panel here to talk about healthcare reform, particularly tort reform. Just to give a little insight before we maybe move into our panel discussion, I kind of want to pass along an anecdote from my practice to hopefully maybe give you all a little insight of what it means to be a physician working within the current structure of our healthcare system, and particularly how tort reform creates some perverse incentives for us as physicians with regards to our management of patients. I was consulted to see a patient about 3 weeks ago. The hospitalist, an internal medicine physician at the hospital, had called me to see this 86-year-old that came in with dementia, and she was admitted with an aspiration pneumonia. She could not protect her airway when she swallowed food. So she had a tube that was placed through her stomach that allowed her to get nutrition. And this physician called me because she had gotten a CT scan on this patient because the patient was complaining of abdominal pain. Well, the patient, being demented, would pull on her tube, and after she pulled on her percutaneous peg tube, she would complain of pain. Now, most of us would look at each other and go, well, it takes just a little bit of common sense to realize that it hurts when you pull on something that's traversing your body, and we would probably stop there. But this physician didn't. She got a CAT scan. So on the CAT scan, it showed that she had, surprisingly, a tube that was passing through her abdomen, but she also had some mild swelling on her kidneys. So that abdominal CT scan then moved into this patient getting a pelvic CT scan. And then that pelvic CT scan moved into this patient getting an ultrasound of her abdomen. And that ultrasound of the abdomen then moved into this patient getting something called a nuclear renogram. And to put this in the context of why this was all done, and was it even necessary, was that this patient had normal kidney function. We're not treating any problems with her kidneys, despite some swelling on her kidneys. This patient's life expectancy, not that it should play into medicine as far as not treating, but treating what is necessary, was less than 6 months. So when I was consulted to see this patient, and I had to look through this bevy of information, I sat down and talked with a physician and asked, why did you consult me? And more importantly, why did we even obtain all of this imaging modalities on this patient? And she said, I was sued 6 months ago. I had an 88-year-old patient that was admitted with intermittent abdominal pain. And when I saw her, she had a perfectly normal exam. So we diagnosed her with a little viral gastroenteritis, a little GI bug that would pass, put her on some IV fluids to rehydrate her, and she went home. Well, that patient died 3 weeks later with an intermittent bowel obstruction that would have never been shown on any type of imaging modality done in the hospital during that stay. But this patient was sued because she did not get a CT scan on that patient. So now she did all of this, she told me, out of perfectly self-preservation. Had nothing to do for her patient. She was just trying to protect herself. But in doing so, she has now raised the medical expenditures for that patient by tens of thousands of dollars. She has actually increased that patient's risk by having to be transferred from her hospital bed to the imaging table 3 to 4 times. Her peg tube could have been pulled out. She could have fallen. She could have been injured. And all of this was done purely out of result of these perverse incentives that arise out of tort. We need to find a way to fix this. And worse yet, this physician, who is a very good physician, I know her well, is actually moving out of the practice of medicine. She said, this has really pushed me to move into the administrative side of things. She had always considered doing that at some point in her career. She's 41 years old. But she said, this just accelerated my decision. And so now she spends 80% of her time doing administration rather than seeing people. And at a time when we are 39th in the states on physicians per capita, we cannot afford losing one physician. So this is why I'm standing here, and this is hopefully why our panelists are here, so that we can discuss ways to improve our tort system, to make sure that our patients are being taken care of well, to make sure that we are finding a way to decrease the use of defensive medicine, to make sure that we're actually ultimately treating our patients the way they need to be treated and allowing us as physicians to be free to be diagnosticians and not work in an era of